Good morning and good afternoon, everyone, and welcome to part one of our webinar, an expert dialogue series around updated guidance from the American Academy of Pediatrics on the treatment of infants with neonatal opioid withdrawal syndrome. Today's webinar is presented by the National Center on Substance Abuse and Child Welfare. My name is Somay Lewis, Program Associate for the National Center. I want to express our immense gratitude to everyone joining us today. We really appreciate your time under the circumstances that we've all been working under. So again, thank you for joining us. This presentation was developed by the National Center on Substance Abuse and Child Welfare, an initiative of the Department of Health and Human Services, jointly funded by the Substance Abuse and Mental Health Services Administration, Center for Substance Abuse Treatment, and the Administration on Children, Youth and Families Children's Bureau, Office on Child Abuse and Neglect. We thank them for this opportunity today.
Thank you so much, Somay. This is Nancy Young. I'm the project director at the National Center on Substance Abuse and Child Welfare. Welcome to today's Ask the Experts session. We are delighted to have Dr. Stephen Patrick with us. Dr. Stephen Patrick is the director of the Vanderbilt Center for Child Health Policy, an associate professor of pediatrics and health policy at Vanderbilt. At the School of Medicine, and an attending neonatologist at Marone Carroll Jr. Children's Hospital at Vanderbilt. So he's both a researcher and a practitioner. So having a clinician be able to share his insights into the research that he's published is certainly a great benefit for us today. He did his undergraduate at the University of Florida, a medical school at Florida State University, College of Medicine, and also Harvard School of Public Health for his MPH. He completed his training in pediatrics, neonatology, and health services research as a Robert Wood Johnson Foundation clinical scholar at the University of Michigan. I think most of us recognize his name from one of the first, or if not the first person to publish on the increase of infants with a diagnosis of NAS and what that looked like just not that long ago as we saw this huge increase in our country. His research focuses on improving outcomes for opioid-exposed infants and women with opioid use disorder and evaluating state and federal drug control policies. With that, thank you so much for being with us today, and we look forward to your presentation.
Well, it's an honor to be with you today and talk about some of our work as well as the new guidance from the American Academy of Pediatrics. It's always great to be with this group, and I've already seen so many friends from various places around the country. So it's really great to be with you all virtually. I wish we were all in person. You know, a couple years ago, I was rounding in our neonatal intensive care unit, and an infant was transferred up to where we were from the newborn nursery with things that seemed pretty classic to drug withdrawal. The infant had about 10% of his body weight that he lost within 48 hours, was jaundiced, wasn't eating well. But when we talked to mom and we did kind of our usual drug screening, she denied any substance use. So we treated that infant, kind of presumed that that infant had some mild drug withdrawal. And it was a few days later that the umbilical cord testing came back positive for buprenorphine. And I'll never forget walking into that mom's room just to talk to her about the drug test. As I walked in, I got down on one knee, as I often do when I'm delivering news that I think is going to be hard. And I told the mom about the drug test. And her first words to me were, "Are they going to take my baby?" She had been taking buprenorphine. It was diverted on the street, as we'll come to talk about a little bit, in part because it can be really challenging to find. She was afraid of what we were going to say when she found out that she was diverting an opioid. And more broadly, she had a challenge getting treatment. So often we see moms who just can't get treatment. And they have varied histories. And those histories are almost always unified with trauma and adverse child experiences. So I'm going to talk about this patient. We're going to highlight some of our work, our team's work, as well as the recent statement from the American Academy of Pediatrics. I'll point this to you all. This is the recent statement that just came out a couple months ago. And you can see we termed it neonatal opioid withdrawal syndrome. We'll talk a little bit about the variation in terminology, As a group, we really felt that, first off, groups like SAMHSA, FDA were already using neonatal opioid withdrawal syndrome. It was also just a clearer term. Just because you have an opioid withdrawal doesn't mean you can't have another substance use. And it's pretty common that even with an opioid, at least cigarettes are also used. So this is the terminology we'll use and we'll continue to use moving forward. This statement, which is publicly available, it's free online, delves in, it's a little bit different, delves into a broad approach to improving outcomes for both pregnant women and infants. So here's our cadence for today. We're going to first do an overall focus on the overall substance use and treatment. We'll talk about neonatal opioid withdrawal syndrome, talk about some communities, the effects in communities, trauma, federal child welfare policies and how they've changed recently. And then lastly, I'm going to close on talking about some of the work that we've done here locally to try to improve care for patients in our community. Well, first, let's start just before birth. So we know that substance use in pregnancy is not that uncommon. These data are from the National Survey of Drug Use and Health. And overall, around 5.8% of pregnant women use some illicit substance during pregnancy. You can see that mostly this is marijuana. That said, look at this compared to non-pregnant women. The use is much lower. We know that pregnancy is the time when women are changing. They are seeking treatment. They're cutting back on substances. And so this is a time to really connect folks to treatment. The other thing that oftentimes is lost in our conversation are legal drugs, both tobacco and alcohol. Look, we still have 1 in 10 pregnant women who use alcohol. And we know that with all this conversation about opioids, alcohol is the #1 preventable cause of developmental delay in children. So when we think about substances, it really needs to be all substances, and it needs to focus in on healthy moms and babies overall. And there's a lot of unifying approaches to that. But of course, we're here to talk about opioids and neonatal opioid withdrawal. These are data from the Centers for Disease Control and Prevention. They talk about the 3 waves, and I've heard some other folks talk about it like a 3-layered cake because they're all going on in different areas. First we saw the rise of prescription opioids. You can see in the purple line on the graph from CDC that began to plateau and then more recently decrease. And then we saw cheaper heroin come in the early 2010s, and then now replaced by fentanyl, far more potent, far more deadly, where we've seen this massive increase in overdose deaths. And of course, this year, we see, again, a record number of overdose deaths. And of course, this has spilled over into pregnant women and infants. Well, so I want to start with treatment because I think treatment for opioid use disorder, it really is the thing that makes everything better. Certainly primary prevention way downstream makes everything better for sure. But in pregnancy, when we have a pregnant woman with opioid use disorder, it's really about treatment. We want to think about stabilizing mom, getting her into recovery, and the subsequent outcomes for the infant. The medications for opioid use disorder, they work. We know the 2 primary that are used in pregnant women are buprenorphine and methadone. We know that they come with a decreased risk of overdose death, relapse, HIV, and hepatitis C for pregnant women. And infants are more likely to be born at higher birth weights, but it does come with a risk of drug withdrawal. The way I usually talk about this is that, if you're a pregnant woman injecting heroin, you go through these rapid cycles of intoxication and withdrawal, intoxication, withdrawal. That not only increases your risk of overdose death, but it's also stressful on the fetus. And this is why we see preterm birth. It's why we see low birth weight. An important caveat for folks to know is that it is exceedingly uncommon for babies that are born very preterm to have drug withdrawal. So what we're trading is essentially by giving treatment for opioid use disorder, we're preventing that very preterm infant at 25, 26 weeks for a later term infant. And that's a good trade-off. And what we might see when we just look at the numbers are more infants diagnosed with drug withdrawal because we prevented that 25-weeker. When we don't capture, those 25-weekers that are opioid exposed very much because we don't focus on the opioid exposure. They don't have drug withdrawal. We focus on the prematurity. It's a good trade-off when we think about treatment. We prevent the preterm birth. We reduce mom's risk of overdose. Sometimes we focus a little bit too much on neonatal opioid withdrawal. This is an email I got from the community that talks about a mom who went through pregnancy, was on buprenorphine, delivered her baby, and didn't have access to treatment, which is sort of funny, in part because somebody paid for this delivery, meaning like a private insurer, perhaps Medicaid, and yet this mom couldn't get connected into treatment. Why is that? So our research team wanted to understand what was going on in communities as it related to access to treatment. And this is a study that we published in just in the fall, a secret shopper study, where we randomized secret shoppers who were either pregnant or non-pregnant with different types of insurance to try to get treatment. And this was really a way that we could look at real-world access in communities for pregnant women. We obtained our data as someone might if they were trying to seek treatment, going to the buprenorphine practitioner locator. We also did the same for opioid treatment programs. This has evolved online now, and now you can go to findtreatment.gov. We do know that people can opt out of this list. However, this is kind of the resource that many folks will point to. In all, we had more than 10,000 attempts in 10 U.S. states, and I'll talk about the approach, but in 10 U.S. states to try to get treatment. And this was using a standardized script. What we found first off is that many folks just couldn't get anybody on the phone. So about a quarter, we called more than 5 times and couldn't get anybody on the phone. Another 20% of the time, we were able to get a medical practice on the phone, but they no longer or never did provide any addiction treatment, meaning it implies that maybe they were buprenorphine waivered, but they weren't actually using it to provide treatment. For other reasons, we also got variations in not getting through. All in all, around 3,400 were able to get through. This is focusing on buprenorphine here. You can see again, this is our randomization. It worked. About half were pregnant, half were non-pregnant, and then same for Medicaid and private insurance. And so what did this look like when a pregnant woman, the only thing that was different in the scripts that they had was I'm pregnant and I need to get treatment versus not being pregnant, a woman of reproductive age. So here's what we found. Pregnant women do have a harder time getting into treatment than non-pregnant women. This is overall treatment. So when someone called, they would call with whatever the most common, either private insurance or Medicaid, MCO in that county. And if they were refused, they could reflex to pay with cash. So what we find is that pregnant women are about 17% less likely to be granted an appointment for treatment overall than non-pregnant women in buprenorphine and outpatient buprenorphine practices. That's not true in opioid treatment programs where we really saw no difference. And you can see a substantial amount of variation in the states that we did this in, from states where we see a big difference in treatment between pregnant and non-pregnant women, like in Florida, and in some states where we see essentially no difference in Virginia. The other thing that we found was that there was a fair amount of difference by insurance type. And what was striking about this is that there was just a large amount of cash pay. Overall, about 40% of pregnant or non-pregnant women were able to get into treatment with their insurance. But one of the things that we found is that many had to resort to paying cash. So about 25% of pregnant women who called to get an appointment within a buprenorphine provider had to resort to cash, and that was a median cost of around $250. And about a third of folks who were able to get an appointment at an OTP had to pay cash as well, and that was much cheaper. But again, it just shows that if you're pregnant, if you don't have the ability to pay cash, and it may depend on what state you're living in, there can be barriers to getting into treatment. So, traditionally, even though we're pediatricians, because we know treatment's important, some of the first recommendations that we have are focused on access to treatment. All pregnant women should have access to medications for opioid use disorder. That's in line with national guidelines, with the National Academies of Medicine recent report, because they've been shown to reduce risk of overdose death and improve pregnancy outcomes. And, this is where pediatricians should partner with state and local child welfare agencies to advocate for funding to improve access to quality treatment. And we're going to talk a little bit later, but, so much about what we've seen in changes to the child welfare system is this focus on prevention and including access to treatment more upstream. So moving now to talking a bit about birth. What is neonatal abstinence syndrome, neonatal opioid withdrawal? whatever we choose to call it, it's a postnatal withdrawal syndrome experienced by some opioid exposed infants. And that some is really important. Oftentimes I hear folks talk about withdrawal as if it means the exact same thing as exposure, and it doesn't. The other thing is that a diagnosis of withdrawal in a baby doesn't necessarily mean anything about what happened prenatally other than the type of opioid used. So you can't say like mom was injecting heroin because the baby was diagnosed with drug withdrawal. It also doesn't mean anything when we think about safety of the environment either. So that clinical diagnosis of withdrawal can be really varied. So we know that some prenatal factors are associated with the development or the severity of drug withdrawal. So additional exposures, if someone smokes or if they use other medications like benzodiazepines, they're going to be more likely to have an infant who has withdrawal. Lack of access to treatment. I mean, we see this in our own clinical setting where if women are not in comprehensive treatment, in part it's maybe a proxy for other substance use, but their infants seem to have more severe withdrawal too. Postnatal factors matter a lot too. And this is what makes this challenging. Lack of standardization within hospitals, exclusion of the mother postnatally, not allowing breastfeeding, these things all make it more likely you're going to get a diagnosis of drug withdrawal. And one of the cases I bring up is in our own clinical setting, as we've standardized the care that we're delivering, we're diagnosing drug withdrawal less among our opioid exposed infants. It's in part because we're focused immediately on that dyad. And so we don't let that infant escalate to having more severe withdrawal. What does drug withdrawal look like in a baby? Well, I think about this where opioid receptors live. And they live in the GI system and the CNS system. So what it looks like is a baby who has poor feeding, vomiting, and can have loose stools. And all of that can lead to dehydration and poor weight gain. Some common CNS signs are tremors and hypertonia, irritability and decreased sleep. I often talk about a baby having withdrawal as a colicky baby times 5. I think for those of us who are parents, we can relate to that. Exaggerated reflexes like the Moro, and the Moro is the very cute startle reflex that babies have. And seizures, although seizures are controversial because they don't occur within opioid withdrawal in other populations. And it's an autonomic signs, things like breathing fast, that's tachypnea, yawning, and dilated pupils. So how do we make a diagnosis of drug withdrawal? It seems like that should be really straightforward, but unfortunately it's not. Let me first talk about kind of screening and observation. So what do we say about screening and observation in terms of how we should screen for substance use as well as observe infants? The American Academy of Pediatrics endorses the exact same thing that the American College of Obstetrics and Gynecologists suggests, which is the use of a verbal standardizing screening tool pregnancy and augment that with toxicology testing when needed. There are limitations of toxicology testing that we can talk about too. Pediatricians should address social risks, including food and housing insecurity. This is something we're building in our program. An observation of an opioid-exposed infant in the hospital should be between 3 and 7 days, depending upon the half-life of the opioid they've been exposed to. So that 3 days, that shorter term, is really if they've been exposed to immediate-release opioids like something like Vicodin. This is in contrast to what we see with infants who aren't exposed. That's somewhere between 1 and 3 days. So what have we seen in terms of diagnoses recently? This is a study that we published just about 10 days ago with partners from the Department of Health and Human Services, from HRSA, ARC, as well as CDC. And I'm just going to highlight specifically on the incidence, but importantly in the study, you can actually go for, we have data from 47 states, and you can see what's happened in your state with maternal opioid-related diagnoses and neonatal abstinence syndrome. And I'm going to go back and forth here on neonatal abstinence syndrome and NOWS, in part because the studies are now, we're evolving, where we have some that say NAS, some that say NOWS. So we've seen a stepwise increase in neonatal abstinence syndrome and maternal opioid-related diagnoses. One of the things to be mindful of here, that line is when we had a coding change in the way we diagnose things from ICD-9 to ICD-10. It's just the way that hospitals code diagnoses, where we see what appears to be this artificial increase in moms being diagnosed with opioid-related complications. But if you just step back from this, you can see this stepwise increase in neonatal abstinence syndrome that mirrors what I showed earlier in terms of overdose deaths. What we know is that there's about 1 baby born every 15 minutes in the US having opioid withdrawal. And importantly, that doesn't include the slew of infants that aren't diagnosed with withdrawal either. So how do we make the diagnosis of withdrawal? Again, this should be straightforward, you would think, but it's not so much. This is one of the semi-objective tools that we have to diagnose drug withdrawal. It's based upon a modification of the original Finnegan score developed by Loretta Finnegan in the 1970s. And you can see here there are some things that look very objective. Like I can probably pick out a fever of 38.4. I can pull those things out. Respiratory rate, I can probably count how many breaths per minute. But some of the things like loose and watery stools, regurgitation, projectile vomiting, they can be really subjective. And so what we find is that we see a lot of inter-rater reliability issues, even within hospitals. If you go from the newborn nursery to the NICU, for example, that's where we start to see some changes and some variability in those diagnoses. Still, having an approach is important, but understanding that there's great variability. One of the things that we know is that even today in 2021, we have no gold standard diagnosis for a drug withdrawal. So what somebody calls drug withdrawal in one hospital may be different in another hospital. We have no gold standard that this is the one scoring system that you should use, even though this is the most common one. And that does create some variability. So there's not a lot of evidence to say, hey, this is the one thing you should use, hospitals. And so, and part of that is we use a standardized tool for diagnosis, like the modified Finnegan. And so hospitals should standardize their process. The other thing to remember is that drug withdrawal should be a diagnosis of exclusion, and that you should ensure that other diagnoses are considered. And that includes things like sepsis or infection and hypoglycemia. You know, we don't want to focus too much on drug withdrawal first. We want to make sure that we've excluded the other things as well. So what is our goal of treatment? It's to control withdrawal and minimize complications. And the first thing that we do with that is non-pharmacologic interventions. And we'll talk a little bit about how the care process changes. But some of that is environmental controls. And the biggest environmental control is to try to keep mom and baby together in a non-stimulating environment. For severe withdrawal, we do treat opioid withdrawal with an opioid, like morphine, methadone, or even buprenorphine in the literature. For us, we treat about 20% of opioid-exposed infants at our hospital with an opioid, and we use morphine as our medication. So we've seen some innovations in care recently, and I just saw a question pop up. There's a lot of them, so I know we're going to address them in a couple of days. So there's no way I'm going to be able to keep up with them. But one of the questions was about Eat, Sleep, Consult, and it is an approach that is being trialed, and even in clinical trials now. It's a pretty simple approach. Even though we have most centers who use a modified Finnegan score, a lot of centers are starting to use this approach. It's pretty straightforward. You know, can the baby eat, sleep? Can we console them? Then they're probably okay. It does have lower rates of treatment with morphine than the modified Finnegan score, than a modification of the Finnegan score, but it's something that really needs study. Most of the literature around the Eat, Sleep, Console score are in quality improvement studies. And they implement the score at the same time that they do non-pharmacologic bundles, like keeping moms and babies together. So it's something that needs more study, and there is study going on right now funded by NIH. Rooming in seems like that should be a really obvious thing. It seems like no way that could have an effect, but there's increasing literature that if you let moms room in with the baby, they're less likely to require pharmacotherapy, medications like morphine for withdrawal, and have a shorter length of stay. I think for me, a lot of the withdrawal that we see is actually mom withdrawal. I've certainly been in clinical situations where I have a baby who is on 3 medicines for withdrawal and a part of the unit where mom can't room in, get the baby over and to a part where mom can room in, and we immediately begin to peel off medications because mom is there holding that baby. Longer half-life drugs like methadone and buprenorphine when compared to morphine appear to be are also associated with a shorter length of treatment and length of stay. So, I've already painted this picture of a lot of lack of standards and a lack of literature to guide a lot of what we do. But part of what we do know works is just doing the same thing every time. One of my favorite studies is looking back to the Ohio Perinatal Collaborative. They put forward a project to look at, was morphine or methadone, was that better and shortening length of treatment for infants? And what they found was basically no effect of that, but what mattered was standardization. So we see about half a length of treatment in Ohio, just among centers who standardized what they were doing. Many of us were part of an effort from the Vermont Oxford Network. This is a collaboration of 1,000 NICUs around the world, and about 200 of them that were involved in this, where we worked to standardize the care that was delivered in hospitals. And what we saw is when hospitals standardized what they did, it's not rocket science, right? We saw shorter length of stay, shorter length of statement. So that even though we have a lack of knowledge in many places, standardizing what you do is important. So here's what we talk about in terms of treatment. And if you look at the actual guidelines, of course, they're longer than this. There's no way in one talk I can summarize the entire guideline. So I encourage you to read them. But this is a summary of them. The first is prioritizing moms and babies together. I saw something just flash up that said normalize the dyad. Yeah, I think in many ways we've over-medicalized this problem. And I mean, imagine if you've had a baby. You're in the hospital, and at 24 hours, somebody comes in, they take your baby, they put it into a loud, chaotic unit. Maybe there's a ventilator next to that baby, to your baby, even if they're not having drug withdrawal. Imagine how traumatic that is for the family and how fussy that baby would be, even if they're not going through withdrawal. So normalizing is important. Have a written protocol and use it. Admission to a NICU is not required. And I think this is important. We'll talk about what we're doing, but traditionally infants who have opioid withdrawal are admitted to a NICU. That is certainly not required. Start with non-pharmacologic treatment. If pharmacotherapy is required, use an opioid. And breastfeeding should be encouraged. We know that breastfeeding reduces the severity of drug withdrawal. It promotes bonding. And there are guidelines for when you should do it. They are consensus guidelines, but in general, if a woman's in stable recovery for more than 90 days, breastfeeding with buprenorphine or methadone is safe and effective. When many folks would say avoid breastfeeding as if there's been relapse within the last 30 days before delivery, though that's what's controversial too. Different hospitals do slightly different things. I want to transition a bit to thinking about communities, because we think about this oftentimes in the medical community as a clinical problem. You have withdrawal, I treat it with morphine. But of course, we all know on this webinar that this is a more complicated problem than that. Just before the pandemic, this was, I guess, about 6 months before the pandemic, I was in my hometown in southern West Virginia. And this is downtown Friday in an afternoon. And you can see not a lot of activity here. My hometown of Bluefield, the population is about half of what it was in the 1960s. My grandfather, had a job on the railroad. Those jobs are not available anymore. The county that I was born in has an overdose rate of about 3 times the national average, and 5% of babies here are born having opioid withdrawal. So this is not a simple story. It's not just about someone starting to use opioids. Of course we know that, but I think oftentimes we approach it as if it is. We know from the adult literature, if you've read the work by Case and Deaton, and they published a book summarizing their work called Deaths of Despair, that adverse economic conditions, lack of opportunity have been associated with deaths related to suicide, opioid overdose, and alcohol. And they disproportionately have occurred in rural communities. And of course, rural communities may be particularly at risk for opioid-related complications due to poor access to healthcare, lack of economic opportunity, and diminished social capital. We wanted to understand if this phenomena was also occurring among infants having opioid withdrawal. So we did a study that came out in early 2019, looking at 580 US counties to look at the relationship between county level economies, access to care, and opioid withdrawal. So you can see in the bottom left part of your screen, the counties, the states that we looked at. I'm going to focus in on the counties here in Appalachia just to show some of just the descriptive statistics. The darker the blue that you see here, the more intense the rate, the higher the rate of neonatal abstinence syndrome in those counties. And these are where people are from, not where they delivered. So in 2019, we're just going to mark through. So what you can see is, of course, a higher rate in those counties, and it is disproportionately in this part of the country and rural Appalachian counties. If you look in rural counties in New York, if you look in the Upper Peninsula of Michigan, it follows a similar pattern. So what we found in this is that overall, we looked at what was happening in that county for the previous decade in terms of its economy. So we used a 10-year moving average of unemployment rate in that county. Of course, this was during the Great Recession as well. So from 2009 to 2015, that 10-year moving average of the unemployment rate increased from 6.5% to 8.2%. And it was associated with higher rates of neonatal abstinence syndrome within counties. And to put some numbers on that, a 2 percentage point increase in long-term unemployment within rural counties was associated with a 34% higher rate of neonatal abstinence syndrome after controlling for other factors within those communities, like access to care. Counties with mental health shortage providers also had higher rates of neonatal abstinence syndrome. This was particularly true in urban communities. What's interesting about that, though, is that if we look at HRSA's designation of what a mental health shortage area is, almost every county is. Like if you aggregate them together, urban communities, 80% are partial or complete shortage areas. Rural communities, 90% are partial or complete. It's almost a silly point to talk about how it's associated with higher rates of drug withdrawal. You can see our results. You can play with both the incidence of withdrawal in various counties. You can also just adjust, like pick a county and change the economic conditions, what the supply is like, and see what the predicted rate of neonatal abstinence syndrome would be. On our website, again, that's childpolicy.org/NAS. Okay, so moving ahead to talking a little bit beyond birth. One of the things in terms of context is just thinking a little bit more about maternal drug use. And this is true if we think about long-term outcomes too for exposed infants. Maternal drug use doesn't occur in isolation. It occurs with poor health often, poor nutrition often, food insecurity, poor prenatal care, social stress, mental health needs, and intimate partner violence as well. All of these can be associated with poor obstetric outcomes. And each of these factors can affect neurodevelopmental outcomes as well. The other piece of this that we often sort of glance by, particularly in the clinical environment, is the role of trauma and toxic stress. The way both our policies as well as our clinical environments approach substance use and pregnancy is often that it's almost as if someone becomes pregnant and we think that they start using an opioid in pregnancy. Like it's like they got pregnant, like I think I'm going to use an opioid now. And of course, we know that's not the case, but it's important to talk about because it's often lost. We know from studies that around 3/4 of women in treatment report sexual abuse, emotional abuse, about half physical abuse. From the ACEs literature, we know that adults who report greater than 5 adverse child experiences compared to 0 are 8 times more likely to be diagnosed with substance use disorder and 10 times more likely to have ever injected drugs. So of course, there's a role of trauma and toxic stress in women and that translates into our families. So why does all this matter when we talk about the broader context and when we talk about trauma? It's in part because our solutions need to consider the context, the dyad, fathers, family members. How can we positively engage prenatally beyond hospital discharge, and beyond hospital walls? Our care needs to be trauma informed, and I think that's become a bit of a catch-all term, but it's true. We need to work to build partnerships as well. Who is part of our care team? And does it include mothers in recovery who can provide guidance? I mean, I'll talk a little bit about some of our work, but one of the most striking things that we've done recently is we have an external advisory board for the program that we're launching here in July, and it includes 3 women in recovery. And so we see these really detailed and impactful conversations happening between women in recovery with folks from the courts, like Safe Baby Courts in Tennessee, and folks from child welfare. It's really striking to have these communications. We know that for many of us, we sort of operate in our own silos, and we are very guilty of that in the healthcare community. Our solutions need to focus at the local level, state, and national policy perspective, and it has to include this context. All right, I'm going to talk a little bit about some of the child welfare policy changes as well, and notably some of the detail that we're going to talk about. The actual legislative text, we're not going to go through verbally, but it's going to be in the handout that you get with the slides because it's a little bit too lengthy to summarize the actual legislative text. So what we've seen is that there's been an increase of about 10,000 per year infants in the foster care system between 2011 and 2017. And this isn't any surprise to any of you. There's an amazing amount of variability from state to state. So my home state of West Virginia, again, more than 4% of infants were placed in the foster care system in 2017, a really striking amount. And of course, we've seen some changes federally to the child welfare system. So I'll just mention here the Comprehensive Addiction Recovery Act that modified CAPTA in 2016 that further clarified the population of infants born with and affected by substance use and withdrawal syndromes resulting from prenatal drug exposure and fetal alcohol spectrum disorder. And it specifically removed illegal so that it could cover legal substances. It specified data that needed to be reported by states to the maximum extent practical. It required plans of safe care. We can talk a little bit that, particularly in our Q&A, what we're trying to do locally with this, that include the needs of both the mother and the family or caregiver. And this is very important. And the development and implementation of state monitoring plans. And we've also seen other recent changes too that range from Family First Prevention Services Treatment Act, as well as the Support Act that had further modification of a plan of safe care. And I'll just highlight what the Support Act has in terms of the folks that are just mentioned in the statute. And it shows the complexity that many of our families face. The Support Act mentions substance use disorder treatment agency, early care and education, Medicaid, public health, residential treatment, the judicial system, MICV, Title V, IDEA Part C, and of course, child welfare. One of the things that's striking to me is that these things do need to be coordinated, but right now, what our families face is an uncoordinated system where we basically, at the time of discharge, go, here you go, you're eligible for all of these things, or you have requirements for some of these things, and it's just not well coordinated. And ideally, that's what a plan of safe care would do, although we know that many states have struggled with implementing those, and certainly it's a struggle for providers as well. So I'm going to talk a little bit about Vanderbilt's model and what we've changed locally in kind of the context of that as well. And because some of it is sort of we've worked to apply many of the principles that are highlighted in the Academy's guidance locally at our own institution. So let's talk a little bit about the traditional model versus newer models. The traditional model for caring for an opioid-exposed infant is to transfer that baby to a tertiary care facility, to separate mom and baby and place the baby in a neonatal intensive care unit. Treatment is separate from the mom. Breastfeeding is either not allowed or at least inconsistent. We focus a lot on the correct medicine. We really medicalize it as opposed to the correct care process. Burnout is common. There's literature to support that in terms of nurse burnout, lack of trauma-informed processes, and care is not standardized. And we see these really long lengths of treatment and stay. I mean, the literature, if you look back in the literature of neonatal abstinence syndrome, you see lengths of stay that are 60 days, 100 days. That's kind of crazy when you think about what withdrawal looks like. If you're an adult having withdrawal, that acute withdrawal does not last 100 days. The newer models transfer to tertiary care facility may not be necessary. Keeping the dyad intact and outside of the NICU when possible should be prioritized. Treatment's inclusive of the mother. I mean, we find when we engage the mom in everything from understanding scoring, helping with scoring, to talking about breastfeeding, not only is it empowering, but it gives us good insight too. Breastfeeding is encouraged and supported. We focus on the care process, not just the medications. Engaging the staff in trauma-informed care, for us, this has been a nurse-driven process. Use of standardized protocols. What we've seen is greater provider and patient satisfaction, and certainly a reduction in length of stay too. So our team and that started on this part is called Team Hope. It includes nurses, physicians, social work, child life, lactation, and volunteers. We've now had a little more than 400 infants in the last 3 years that have come through the program. And part of the issue is just standardizing what we do. And you might have had a mom who was in our prenatal clinic who was told, you can breastfeed. And then they go to the newborn nursery and they're like, oh, you can't breastfeed. Then they go to the NICU and the NICU says, oh, you can breastfeed. And then if the NICU gets full, and even in a 120 bed NICU where I work, sometimes it gets pretty packed. They may go to the general inpatient floor. And then when they get to the floor, they're like, oh, yeah, a different message on breastfeeding. So just standardizing that's important. We've also thought a lot about, of course, like our model is that first model of keeping moms and babies together and simplifying, normalizing, just keeping the dyad together outside of the NICU. So no baby that is opioid exposed goes to the NICU any longer in our hospital unless there's a medical reason why. So like if a baby has respiratory distress or breathing difficulty, they'll go to the NICU, but they don't go to the NICU just because they've been opioid exposed or have drug withdrawal. So that enabled us, once we sort of simplified that and we standardized our process, to start thinking beyond and thinking more broadly about who do we need to engage and what we need to do. And we think about, while we have moms and babies in our hospital for 5 to 10 days after birth, what do we need to do to optimize them for the future? And part of this starts with bonding and partnering in the hospitalization itself. Things like breastfeeding, engaging the family, assessing mom's needs and the family's needs and follow-up, assessing other risks, including hepatitis C. And it includes post-discharge needs like home visitation, child welfare, like thinking about a plan of safe care. Are we connecting to early intervention? In many cases, we weren't. More frequent pediatrician follow-up and actually contacting a pediatrician to say, hey, this patient's coming, and coordinating with maternal treatment too. I mentioned hepatitis C, and I'll take a little aside. It may feel a little tangential, but it's really important. It's important because we've seen a doubling in hepatitis C among pregnant women. Nationwide, there's around 2.5 million people diagnosed with hepatitis C. This isn't just a disease of baby boomers anymore. It's now bimodal. You see young adults and then baby boomers. That's the way that it's coming. And it's been associated with injection drug use disproportionately in rural communities too. So it's another complication for maternal child health that I think often flies under the radar. Exposed infants, if they've been exposed to hepatitis C, that's almost half of the patients that we care for. They have to be followed for evaluation to see if they've been exposed, if they also convert to having hepatitis C. Only about 6% of infants who are exposed go on to have vertical transmission or get hepatitis C. Higher if there's a higher viral load or if there's HIV co-infection. But the problem with hepatitis C is that it's completely silent. If you don't test mom for it, or if you just kind of forget about it for the infant because maybe you're focused on other things, it just goes unnoticed. Maternal antibodies can persist for 18 months. And so traditionally what we've done is that we wait till 18 months to test the infant. So we did a study recently in Tennessee to look at just the whole group of hepatitis C exposed infants born in Tennessee enrolled in Medicaid from between 2005 and 2014, and we followed them for 2 years. Only 22% were tested. And we found that there was, and this was in models accounting for a slew of other factors like engagement in the healthcare system, prenatal care, that African-American infants were 60% less likely to be tested than Caucasian infants. The only rational explanation for that is just systemic racism. So it's important for us to think about hepatitis C because I think it often gets missed. We can now test it earlier too. Guidelines are evolving to where we can do RNA-based tests before 6 months, as early as 1 month. In our own system, we now do it 2 and 6 months for hepatitis C, and then confirm at 18 months with an antibody test. So let's talk about discharge and what we're doing, and then I'm going to close with kind of the program that we're preparing to launch. So we've had a pretty engaged group of folks, and this is one of our hospitalists who has a great beard. It's a great beard, but is also focused on what are we doing in terms of discharge. Pretty straightforward. Like, what should we be doing? We should be making a pediatrician appointment. We should be thinking about hepatitis C. We should be thinking about infant development. We should be making referrals to early intervention and home nurse visitation. So we look to see, okay, great. How often are we doing that? And we should be doing that every time for infants. So here's what we found. When we audited, we were doing this every time for every infant, 1% of the time. 1% of the time, among a group that was pretty engaged in this. We just don't think about discharge. When we identified it as a target pretty early and then we audited, just talking about the audited results, of course, began to change behavior. So we just talked about it, started to improve. We made some checklists. We talked to house staff about this, and it increased. And then, of course, almost 100%. And of course, we lost the social worker, and then it went down. This is persistent now. We are now in the 90s in terms of our discharge process. And this was a first step for us and just trying to think beyond. As neonatologists, by training, we, intubate babies, we resuscitate babies, we think of ventilators. We don't often think about issues beyond. And so it's really important, particularly for our patients. Here's some of our measures just from the last year from Team Hope. In terms of in-hospital care, almost all of our moms have roomed in for at least a portion, and most of that with biological mother. 70% who were eligible received, and that's most of our moms, received breast milk. We're receiving breast milk at discharge. Important, many of our moms choose to pump, in part because of sexual trauma. Some moms may not choose to breastfeed, but they may choose to pump. Giving moms option and empowering them to make those decisions is important. We've had 74% overall that have completed the discharge, and about 90% are discharged home with their biological mother. We've had 2 readmissions within 7 days, really unrelated to withdrawal. Overall, our median length of stay for all comers is 5 days, 11 days if you had any pharmacotherapy. So I'm talking about the AAP recommendations here. Avoiding discharge on pharmacotherapy is important outside of a comprehensive program. I mention this because what we've seen, particularly early on in the crisis, is that some hospitals would either begin treating with an opioid and then add phenobarbital, or they would just load an infant with phenobarbital and discharge them home. Phenobarbital is a medicine we use to control seizures. It essentially cools down the brain, but it's also been associated with developmental delay. What we found in a recent study, and now actually the data are getting old, it's from the early 2010s again, among infants in Tennessee diagnosed with neonatal abstinence syndrome, more than half were discharged home with medications. Most of that was phenobarbital because it's easy to get. You can get it from a pharmacy. What we found was that discharge home on medications decreased length of stay in the hospital from, modestly by a few days overall, but it greatly reduced length of treatment. The length of treatment overall went from 20 to 60 days. And the tail end, the infant who was on treatment the longest, was on phenobarbital for almost 200 days. And again, there's no real justification for that. Use a discharge checklist. An infant, before you send them home, should have no clinical signs of NOWS for 24 to 48 hours. We need to focus on connection to early intervention, early head start, home visitation, et cetera. For us and the healthcare, we oftentimes forget about these really powerful early childhood education, early childhood programs, address other concerns like hepatitis C, and coordinate with child welfare, including plans of safe care. So as I begin to wrap up, thanks for tolerating. This is almost like shock and awe. I know it's a lot of slides, but we wanted to get this in, and then we're gonna do some Q&A later. I'm gonna talk about our MOM model. So Tennessee is one of the 10 states that was granted funding from the Centers for Medicare and Medicaid Innovation to create a model for pregnant women with opioid use disorder and their infants. It begins in pregnancy and goes to 1 year. And we're leading that model here at Vanderbilt in partnership with TennCare as well as the 3 Medicaid managed care organizations. This is the area of the state that we're focused on. This is Middle Tennessee. So what are we doing? What we find is, like, I spent most of this time talking about problems. This is a problem, that's a problem. So what we're going to try and do is fix those problems. And we've been in the planning phase for some time. We're launching in July. So here's what we're doing. In the prenatal period, we're creating coordinated care, and we need to update this as we're evolving this. But it's care that includes mom's mental health, infectious disease, addiction treatment, prenatal care. It focuses on lactation, intensive outpatient programs. So as of 2 weeks ago, we have one site of care where we're going to be able to deliver prenatal care, addiction treatment, psychiatric treatment with a collaborative care model, and we're going to be able to deliver infant care too, including providing vaccines. Same side of care, we're going to be able to do intensive outpatient program as well. In the hospital setting, we're going to continue to focus in on keeping mom and baby together. But for many of our moms who weren't in treatment before how can we connect them with treatment in this pretty critical phase with addiction medicine consults, child life? For infants, we're going to focus on minimizing morphines, risk-appropriate care. We've done some work to try to assign risk of withdrawal. What I mentioned earlier was that we basically observe infants based upon the half-life of the drug that mom was using. But we know it's more complicated than that. Male babies, for example, are more likely to have withdrawal than female babies. So we created a risk score that we're working to potentially implement in this too. And then developmental screening and prevention. After discharge, and if we look at, like, we're using a quality improvement framework for this. If we look at our SMART aim, it is focused on relapse, 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 relapse. If we prevent mom from relapsing, we keep her engaged in treatment, that's where we see improvements, not just in pregnancy, but beyond. So everything goes back to trying to prevent relapse, all the things in our driver diagram. Home nurse visitation, connecting again with early intervention, developmental monitoring. We have a developmental psychologist as part of our team who's helping inform these systems, as well as pediatric well care. And it's not just well care, we're working on developing a medical home too. All of this is pieced together with peer navigators. These are moms in recovery that are going to be like a Sherpa to guide moms through treatment. And the goal on intake, we are going to assess things like food insecurity, housing insecurity. And even though we can't pay to fix many of those things, part of what we see is that there are potential resources for things, even childcare, that are not well connected or not coordinated. So it's on us to try to coordinate that and to try to improve that. That's the goal. We'll see how this goes. And we're launching in July at Vanderbilt. Okay, so as we think about this, pregnant women and infants have been substantially affected by the opioid crisis. And here's the thing, they often fly under the radar. As we hear policy solutions, as we hear about folks talk about this, we don't hear infants, moms talked about. This is something that I hope we start to hear more about, particularly as we start a new administration. Moms and babies should be at the forefront. Helping moms and babies out not only improves outcomes immediately, but for kids for a lifetime. Our approaches must be tailored and address their specific needs. Improving outcomes begin before birth. Engaging mom in treatment is really important. Healthy moms have healthy babies. Healthy moms have healthy babies also seems like something that should be basic, but oftentimes we see the dyad pitted against each other in ways that don't make a lot of sense. Keeping the dyad together, both in our policy as well as our clinical models, makes a lot of sense. This is not just about drug use, it's about the community, economic opportunity, social network, and trauma. And this is why our policy solutions need to be mindful of that too. The opioid crisis may be a vehicle to improve maternal-child health systems. I say this because the positive piece of this too is that people are coming together, not just in communities, but also federally. We see groups coming together to hit some of these things that are fragmented. That, what if in 10 years we're talking about methamphetamine use? What if we're talking about cocaine? How might these innovations improve maternal child care and not even just for substance use for a generation? I want to acknowledge my co-authors at the American Academy with the American Academy of Pediatrics, Wanda Barfield from CDC and Brenda Poindexter from Emory, as well as our committees, the Committee on Substance Use Prevention, as well as the Committee on Fetus and Newborn. Here is my contact information as well, and feel free to email, and I can either try to answer questions or connect you to folks. And I'll hand it back to Nancy, and I look forward to having an engaged conversation on Thursday as well.
Thank you so much, Dr. Patrick. This has been a great session. And actually, we're a couple minutes ahead of schedule. So we have 5 minutes left, a couple minutes we need to wrap up at the end. But let me try one question, because there were a lot of questions that came in related to breastfeeding. And a whole gamut using pregnant women that are using medication-assisted treatment, encouraging breastfeeding, how to get that accepted in not just the hospital, but by child welfare, by the court. What's your experience with that, and how do you support moms and babies related to breastfeeding?
Well, part of it is talking about it and focusing on it. So what we were able to do in our own program was to get a private foundation to give us an FTE of a lactation consultant who was focused specifically on this population, implementing our guidelines. And our guidelines are the same as the national guidelines. They're same as what we put in the Academy's report too, where if a woman's in recovery, it's not only safe, but it's effective to promote breastfeeding. We are struggling with implementation like everybody else. So what we're hoping to do is to push those lactation consultants that to have that prenatally and to have some post-discharge help too. Some of our partners in the community, like Nurses for Newborns, it's a home nurse visitation program. It's a promising program. They also provide lactation support. Part of this, I find, it's just about communication. I think there's a lot of misconception in everything, particularly when we think about engaging with the child welfare system, on things like drug testing, its issues, on breastfeeding. So part of that partnership is having this engaged conversation, local partnership, talking about the evidence, and just keeping that up. I mean, again, we have like not only conversations with DCS locally in the hospital, but also a good partnership with our state DCS partners too, where we can talk about this, where we can share in training. So I think this is where just breaking down silos, talking about what works, and then engaging moms in really positive ways. It's really empowering.
Great. I loved the conversation about using women in recovery also for engaging women. So that's a terrific strategy. So thank you again.